Thank you, everyone, and thank you to AOTIC that happens to be one of the cancer organizations in the world that is near and dear to my heart. And is the #1 cancer organization in Africa for this invitation for the Mayo Clinic to present our global oncology initiatives. We're really excited to really show Africa some of the work that we are doing in Africa and happy to give our presentations today. So let's see. So the way we're going to do this is that first of all, I'm going to give a really very brief overview of the Mayo Clinic Comprehensive Cancer Center COE Global Oncology Initiatives. And then I'm going to do a little bit of highlight on some of our work in prostate cancer control in Africa. And then I will pass it on to somebody that I called my brother, Dr. Louis Roberts, to talk about our liver cancer control in Africa. The email that you see at the bottom is the email that you can send a message to us about any questions that you have, or if you want to find out more about the initiatives that the Mayo Clinic Comprehensive Cancer Center has, or you're just interested in learning more about our program. So first of all, I want to apologize. I'm going to really quickly go through the slides because I believe the most important thing is for you to really get a taste of the work that we are doing. We are happy to talk to you more about this work, of course, when it's needed. So I'm going to go really fast because I would like to give Dr. Louis Roberts a chance to also talk about liver cancer and then give about 10 minutes or or something around that for us to do a Q&A as well. And I believe you can put your Q&A in the chat. So just introducing you to what we do at the Mayo Clinic Comprehensive Cancer Center, COE Global Oncology. First, I want to give you an introduction into the Mayo Clinic. Yes, we are the #1 hospital in the whole world, and we work very hard to attain this status. Mayo Clinic is also the #1 hospital in the nation, and in Minnesota as well, as a site in Florida is the #1 hospital in Florida, and a site in Arizona is the #1 hospital in Arizona. This slide I am borrowing from our executive director, Dr. Sherry Willman, gives you a taste of what Mayo Clinic is. Mayo Clinic really is very well laid out in different areas across our catchment areas within the nation, as well as the fact that we have one in Minnesota, in the Midwest, that covers 3 states. We have in Arizona, we have in Florida, and we have what we know as the Mayo Clinic Health Systems as well that cuts across the nation. Now, within the Mayo Clinic Comprehensive Cancer Center is an office that is called the Office of Community Outreach and Engagement. And on that office is where we have a global oncology initiative. Within that office, I work very closely with 2 partners, Mr. Doug Morrell, who is the our enterprise-wide operations administrator, as well as Ms. Monica Alberti, who is our enterprise operations director. So the 3 of us actually work across the enterprise in leading the Office of Community Outreach and Engagement. Also, each of us serves as an associate director as well as a partner, who could be, in this case, an operations manager in Arizona or a program manager in other states. Also, we also have a program that is dedicated to inclusive research led by a program manager, and then we have a program evaluation, and then you're going to learn a little bit more about Ms. Fahia Umar. So this is the layout of a global oncology initiative within the cancer center. And as you can see, I work very closely with Fahia Omar to be able to lead our global oncology. So please, if you have any questions, anything, just Fahia Omar is the most important person in all the presentations that you're going to see. So you want to email her at the email that is right there. The way we operate within our global oncology initiative is that we have cancer consortia leads that are actually either funded by the National Cancer Institute, or funded by Department of Defense, or funded by pharma. And the 3 of us that lead 4 cancer consortia within the cancer center. So our mission within our office is to drive meaningful, sustainable, and impactful change that advances cancer health equity within our catchment areas and beyond our catchment areas. This is why we are able to foster or put some of our programs that are focused on global oncology. And we have 4 aims within the Office of Community Outreach and Engagement. And the aim that focuses on global oncology is aim 4 that talks about expanding outreach beyond the catchment areas to national and global initiatives. So this gives a really good summary of all the activities that we have within sub-Saharan Africa. A lot of the work that we do are focused on research, and you can see from the GOI supported grant awards that we have numerous grants. We have a lot of activities that cuts across multiple cancers: liver, prostate, breast cancer, brain cancer, across the enterprise. And the blue that you see is where we currently are in Africa. Also, our Cancer Center Global Oncology Initiatives really is doing much more than research and training. We also recognize that social determinants of health is a big issue in cancer control everywhere. So we have one of the evidence-based interventions that we have within a catchment area, within a cancer center, that is called the Wellness RX, that is called Nutrition RX in Africa. And we have launched this program in 3 countries in Africa with over 2,000 Africans who have been served by this. So that is all about Mayo Clinic Comprehensive Cancer Center. I am now quickly going to go on to how we collaborate in the area of prostate cancer control in Africa. Just to give you a sense, really quickly, this is prostate cancer statistics within the world. What you are going to see with the prostate cancer statistics, and what I feel is the most important thing, is what is within my right hand. If you look at the changes for prostate cancer from 2022 to 2045, you are going to see that the continent with the most significant change for prostate cancer is Africa. There is going to be 134.2% change for prostate cancer deaths, mortality from 2022 to 2045. And dealing with prostate cancer, or dealing with cancer in general, is really very complex. This is something that we found out in the work that we've been doing. Way back in 2004, we recognized that to be able to really have a way of conquering prostate cancer all over the world, it has to be multi-level, collaborative, translational, as well as global. And another thing to remember, especially for those who are early career stage investigators, is that when you are doing this work, you really need to focus on the root of the burden of cancer. So the way we work in prostate cancer globally is to be able to look at the socioeconomic, clinical, cultural, behavioral, psychosocial, biological, and environmental factors that really, really do impact prostate cancer, and figure out how do we address these factors? Because it's not just looking at biological factors alone and you think you're going to make a difference. You cannot make a difference. You have to look at all those factors. And for you to be able to do this, it requires what is known as consortium science. I have to tell you, I have been over 30 years in academia, and I want to tell you, even within Africa, you are never going to be able to effectively have a way of really addressing cancer if you are working by yourself. There's really a no-person loner. The success that we have made in actually being able to move the needle is really because we are working in teams and we are working in consortium science. So for anybody who is, currently in Africa and you're wondering, how do I break into this? Please, there are multiple cancer consortia that are affiliated with the aortic organization. And you can join any one of these because membership are always free for this consortia, so that you can work and think together and leverage all the resources that are within this consortium for you to be able to work to contribute to eliminating cancer. I want to introduce you to 2 consortia that are one of the 4 consortia within the Mayo Clinic Comprehensive Cancer Center. The very first one is the Prostate Cancer Transatlantic Consortium, which I founded in 2005. As you can see, we have been working together really closely with over 70 sites in the United States with over 35 million funding, which is all the funding that comes to all the investigators. That there are multiple publications. I want to highlight two of the scientific discoveries that we have in Africa. Through our consortium, we discovered that the mutations in DNA damage response genes were higher in Nigeria. Prostate cancer samples and a portion correlate with African ancestry. We also discovered that Nigerian men BPCH contains significant germline alterations, interactions, and increased somatic alteration frequencies that impact apoptosis. So there's a lot of discoveries that we do not only in genetic but social determinants of health, clinical trials, and we work together and do a lot of work. You can look at a lot of our publications or reach out to us and we'll be happy to. But one of the ones that I really want you to see is that despite the fact that we were founded in 2005, yes, we are going to be 20 years this year, it was also necessary, even as a consortium, to join other consortia and join other institutions and organizations to be able to even improve in the work that we do, especially in Africa. So that is kind of what led to the birth of the IKEA Consortium. Again, borrowing this slide from one of the presentations that was done by a Cancer Center Director, Dr. Sherry Willman, but this is the information about the IKEA for Black Men Consortium, which is really much more of an alliance of multiple consortia focused in 15 countries. Majority of the countries are in Africa with now universities. And you can see the leadership is very diverse. One of the things that I want to point out within the leadership is that the leadership actually include prostate cancer survivors who really are very crucial to our understanding of what is going on with prostate cancer across the world and also within Africa as well. And the I Care for Black Men Consortium is actually funded by Department of Defense with almost 18 million direct funding from Department of Defense. But in addition, Mayo Clinic has made significant investment with leverage funding, as well as the City of Hope and Georgia College also provided additional funding. We have a little bit over $25 million that is sunk into this consortium to be able to eliminate the burden of prostate cancer disparities experienced by Black men globally. A majority of the sites that we have are actually in Africa. I'm going to quickly introduce you to some of the projects that we are doing within the IKEA Consortium. Here's my project that I co-lead with Dr. Ngufo as well as Mr. Merriweather. My project actually focuses on using artificial intelligence and technology to be able to support men that are diagnosed at the point of prostate cancer disparities. So we have a system that is called the Vera system, is virtual reality assistant, so that when men are diagnosed with prostate cancer, they are immediately able to get emotional support, psychosocial support, as well as navigation for social determinants of health navigation. This system is developed and we're currently doing in the phase of doing a clinical trial to test it out among different Black men, including African immigrants within the United States. Another project that we have within the ICARE is a care at home project, is Care Beyond the Walls. So this is a project that takes a look at not only being able to treat advanced and metastatic prostate cancer within the hospital, but how can we treat this at home with men? And the project has already started, and I think there's about 10 men that are recruited within this project in the United States, including African immigrants. The third project is focused on looking at African immigrants as well as Caribbean men, which is going to be the second phase of it. But it focuses on really understanding what really determines the way that we really need to understand identifying diagnosis and treating sub-Saharan African men within the United States. And as you can see from the model that is developed, and this is led by Dr. Kaninjik, Dr. Gladys Asiedu, as well as Mr. Emmanuel Agbola, who is an African immigrant in the United States diagnosed with prostate cancer. So you can see we are looking at a whole lot of factors that influences that. I am actually very passionate. It's not my project, but I love this project because this project really is being adapted in looking at the role of vitamin D levels and effects of supplementation on the level of immunity in Nigeria and USA Black prostate cancer patients. I love this project because it's kind of one of the low-hanging way of actually addressing prostate cancer in African men by looking at whether vitamin D can contribute to the immunity that they have. So this project is opening up a clinical trial in Nigeria, and the trial is led by Dr. Colon Otero, as well as Professor Popola and Dr. Joshua Abiodun is the prostate cancer advocate who is going to be there. We are awaiting NAFDAC approval, and I know that it has kind of taken a long time, but we are looking forward to opening this most probably within the summer. This is a study led by Professor Rotimi and his prostate cancer advocate, Captain Ayinde Yahaya. And this study is literally based in Africa and is looking at how to unravel the genome metabolomics landscape of prostate cancer survivorship in ethnically diverse Black men. I think they have most probably about 15 countries in Nigeria that contributed to this study. And they have really found a lot of unique things that includes the fact that prostate cancer survivors have higher levels of circulating tryptophan within their system, and their lipoprotein component significantly is correlated to the ratio of free PSA to total PSA. This is mainly based in Africa, and this is what they are finding in Africa. So you can see that the science is improving. Really proud of this project by one of our early stage investigators who is really looking at how do we begin to understand the experiences of Black prostate cancer survivors relative to prostate cancer and survivorship care. This is a way for us to be able to use artificial intelligence that once a person is diagnosed with prostate cancer, they can use artificial intelligence to document their experiences. And if there's a flag for the intervention that needs to, most probably, for example, if their stress level is high or they need social determinants of navigation, at that point that is really needed, they can be provided an intervention that will support them. So I'm really proud of this project. I'm looking forward to it being able to be disseminated and adapted in Nigeria. This is another project that is using the VIRA system, the Virtual Reality Assistant System. But if you remember, the VIRA that I'm leading is actually at the point of prostate cancer diagnosis. The one that Dr. Kimley Chan Ashing is leading, and Pastor John McCall is the community MPI on this project, actually focuses on beyond the point of prostate cancer diagnosis. So once you are diagnosed and you start your treatment, how do we begin a survivorship care plan that is tailored to you until whenever? Because the really critical part it's not only about getting diagnosed and treated. The critical part is maintaining survivorship care plan and making sure that there's no recurrence or there's no second cancer. So this project has really developed a very comprehensive artificial intelligence on how to be able to use emotional support, treatment support, psycho-oncology support, social determinants of health navigation, to be able to provide a tool for men consistently till whenever that they can use either on their laptop, their iPad, or their phone and access intervention immediately. So as you kind of are seeing, for us in the ICARE consortium, the real interest is focused primarily on looking at survivorship. How do we maintain survivorship? How do we make sure that people are getting the treatment that they need? And leveraging artificial intelligence as well as technology to be able to do this. So that is kind of about our projects. I know this is the ones that you are really most interested in, because one of the things that we really want to share is the fact that we are not only doing the projects, there are opportunities for you to actually partner with Mayo Clinic Comprehensive Cancer Center or partner with one of the consortia that we have with the Mayo Clinic Comprehensive Cancer Center. The ICARE this year launched a pilot program. Sorry, it just ended in January 31st. And Dr. Kaninjig or anybody who is affiliated with ICARE, if you're on, please drop in the chat information about how many submissions that we got with this developmental research program. And I know the review is going on and we haven't announced it. This is going to be every year, so you may have missed it this year. It is going to be again due again in January 2026 for you to be able to apply for this. So this is focused on prostate cancer, and it's a developmental research grant. I am so excited about this project because for the very first time, we did it in such a way that we actually had it in French as well. So not only can you submit in English, you can submit your grant in French. And this is an area that we are seeing that there's disparities. Anglophone countries are often more able to apply for grants, while Francophone countries are kind of a little bit behind. This is the first time within a consortia that we would actually say you can submit your project in French. Guess what? We got more eligible grants in French than we got in English. I was surprised. So this is where it is so important that we need to kind of have representation and give other people who may not speak English a chance to be able to do it. So I'm really looking forward to the studies that will be funded in the francophone countries. Another thing that we're excited about, and I think this ended yesterday, so I don't know whether Dr. Solomon Rotimi is on, whether he's expanding it, whether he knows how many that he got so far, but you can put it in the chat. We are excited about a partnership with the National Institute for Cancer Research and Treatment, which is NICRAT, to be able to provide 2 postdoc positions for NICRAT. This is IKEA funded grant, and we are going to be training 2 postdocs. So this is going to be an exciting thing for them to be able to learn either in biological, social or environmental risk factors. Dr. Rotimi or anybody who knows, please let us know whether the deadline has been extended or not and the criteria for this. Another thing that I'm very excited about the work that is being done in Africa is the work that is being led by the African Behavioral Center, which is by Dr. Catherine Oladoyinbo, as well as Dr. Ogo. And this is focused on being able to offer for the first time an international global oncology certificate programs for in the area of cancer control. And this is for early career investigators and postdocs. And I believe that this just came out. So if you are interested, you can let us know if you are interested. I believe they are not even started the application process yet, but it just recently came out. And then we also have a training program for advocates as well, which is going to be April 22nd to 25th. So if you are interested, please get in touch with us. So we are offering a lot of training opportunities, not only for researchers, but also for advocates as well. This is one of the things that I'm more passionate about. Like I told you, there's not, doing research, having interventions, focus on biological, behavioral, all the stuff, without focusing on social determinants of health, really is not helping cancer control in Africa. So I'm very excited by another program that is led by the ABBA Center, Dr. Ladoyinbo, and Dr. Ogo, that focuses on food as medicine. So we have actually served over 2,000 Africans in Nigeria and Cameroon. We are going to be in Côte d'Ivoire in March. This is a project that was adopted by from the Mayo Clinic Wellness RX program. So if you are interested in having something similar in your country, please reach out to that email that I provided, and we will link you to Dr. Ladoyinbo at the ABBA Center to be able to see how they can support. But this is mainly for sub-Saharan Africa, and it provides health education, and then people get groceries as well. This is an example of what was done in Nigeria. You can see Dr. Ogo right there doing the prostate cancer education, but you can see the bags and you can see what is contained in the bags of food stuff that is really addressing social determinants of health in the case of food insecurity. And I'm almost done. Sorry, I'm talking so fast. Another innovation, which is actually led by two of our early stage investigators, Dr. Bolajoko as well as Dr. Fullwood at Mayo Clinic, is what is called prostate cancer conversations. We are looking at different ways in which we can actually talk to men about prostate cancer, educate them, and continuously enroll them in a database that will link them to additional resources and also link them to being able to participate in clinical trials. The very first one was led by Daniel Lee, who is a biostatistician, caught the bug for prostate cancer advocacy and is now and now wants to lead a lot of prostate cancer conversations for us. But you can see where a unique group of men is a launch and dine or program 2 hours of just empowering Black men about prostate cancer on clinical trials, education, prevention, screening, and survivorship. It is coming to Africa. Dr. Bolajoko, if you are there, please announce the places that we are going to be in Africa in the chat. So I'm calling on a lot of people or anybody who is with IKEA. I don't know whether you're on Emelina. Go ahead and let us know where we're going to be in Africa. We are open to global collaborations with IKEA, so feel free to snatch this. We are also going to be providing slides as well. Prostate Cancer Transatlantic Consortium is also very open to collaboration, so feel free to take a screenshot. I want to actually recognize the team that we have in Africa. They are doing amazing work. They are going from one corner of places in Africa. They were in Maiduguri last week, and now we're going to Cote d'Ivoire in March. Just, making sure that we are closing the gap for cancer disparities through research training, as well as through community outreach and engagement. And we are recruiting from Francophone countries. So if anybody speaks multiple languages, and I think the person can be in Cameroon or Cote d'Ivoire. So please let us know. Inviting you to the Iron Man Conference, which is coming off in Nigeria, September 4th through 6th. And I believe that is the end. And I'm going to quickly hand over to Dr. Louise Roberts. I see that Dr. Abriola Ibrahim is here, so she might want to say one or two things. Sorry, we started really quite early because we wanted to leave time for questions and answers.
Thank you very much for starting this. So here's the fun fact. This is heavily attended because once this topic came up, everybody was willing and looking forward to it, and we are not disappointed at all. My apologies for joining late. You don't need any introduction, so I'm sure I didn't need any 2 minutes to introduce. I had problems with logging in, and I'm in Chicago. I don't know, so we can also have internet problems also here in Chicago. So yes, and Prof. Lewis does not need any introduction, and I look forward to having him discuss his own part. And we have I'm sure people have a lot of questions because I'm here typing my own questions too. Please go ahead, Professor Lewis.
While we're waiting, I'm happy to continue sharing some of
the stuff. If you want to go ahead and continue sharing.
So I'm trying to look at questions and comments and postings of what has been posted. So you can see some of our African staff are on introducing themselves, so keep doing that in case people want to get in touch with you. Thank you for posting the Mayo EDU email. That would be the best place to be able to get in touch with us, please. I see that, oh yes, Dr. Kaninje posted 46 application submitted in English and French. The postdoc application, unfortunately, has closed. It closed yesterday. We have 10 applications, and we are only going to pick 2. But we are willing to most probably have a conversation with AOTIC about having a postdoc position with AOTIC as well. So definitely can do that. Yes, Dr. Ibrahim.
So I think that what we're going to be doing is, because we have this session every Tuesdays of every month, if you have openings or things like this, you can send it to us so that at the end of all the discussion, we can actually post it and everybody has the opportunity to see that. And, so we can see what everybody is doing so we don't have to wait. wait till whenever a Mayo Clinic is presenting, so people don't miss the opportunity. And hopefully we'll be getting more and more people to attend, because I think overall we have what we call social media fatigue, because everybody gets a lot of like 100 emails a day. So you can open all of it and then you miss some opportunities. But in times like this, when we talk about opportunities, like, oh, this is what is happening, this is the prospect, and what have you, I think hopefully next time we can always have that and share all those things, the expectations and all that. Thank you.
That would be perfect. Perfect. There's a question about how to connect regarding the prostate health program. Please email the Mayo EDU email. That would be the best. It was posted by Fahia Omar. Please, it's mcccoe@mayo.edu. That would be the best way to get the centralized way to get all the information, and Fahia will make sure that she gets all the information across.
Okay. Sorry about that. So I'll talk a little bit, I think, about our efforts in the area of liver cancer, and I'll try to be quick. I know we're running short of time. And I'll talk probably mostly about some of the epidemiology and prevention. I'll talk about early detection, and we can maybe have discussions about some of the work we are trying to do to improve treatments, which I think includes the really important dimension of trying to figure out ways to improve the access to clinical trials in Africa. And so I think that's another focus of our work. Some disclosure. So I think the key message for the first few slides is that we have a global burden of liver cancer that is high, and particularly in Africa, the years of life lost are many, particularly because we have a young age of onset of liver cancer in Africa. And the liver cancer epidemic in Africa is now. It's not something that we are looking for to happen in the future. It's happening as we speak. It's an example of a young man who presented with abdominal swelling, a palpable mass, a bruit over his liver, and much of this is a solid mass in his abdomen that you this big protrusion. On the other side, on the right, is an ultrasound that was brought to me when I gave a talk to Ghana a few years back. The physician brought an ultrasound from an 18-year-old woman that he was seeing with chronic hepatitis B. This is from 2021. One of our colleagues from Georgia, from Atlanta, actually goes to northern Ghana every year, a couple of times, to work at this Baptist Medical Center in Nalerigo. Here is a 14-year-old person, and this is an autopsy. It's a medical certificate of the person's cause of death from liver cancer. So liver cancer also globally happens to be the most lethal of the major cancers. So by incidence, you see the cancer incidence ranked in the top 6, lung through liver. And so about 850, 860,000 liver cancers estimated in 2024. But look at mortality and then mortality ratio, which is the proportion of individuals that are diagnosed that will die within a year of diagnosis. And you can see that liver cancer has the unfortunate circumstance of having the highest mortality ratio, even higher than lung cancer at 87%. So another way of thinking about this is that 1 year survival globally for liver cancer is only 13%. And liver cancer deaths then are highest in Africa and Asia. And you can see where we have rates of 8, above 8 per 100,000 per year across much of sub-Saharan Africa, as well as in a lot of Asia. And I'll note particularly Egypt, because we'll talk about Egypt in a little bit, where they had very high rates of hepatitis C, in part because of nationwide elimination program for schistosomiasis, which was done by injections of praziquantel and had the unfortunate side effect of resulting in the dissemination of hepatitis C throughout the population, so that 5 years ago, about 10% of adults in Egypt were positive for hepatitis C. So if we compare the cancers in Africa by incidence in terms of major cancers, you can see here incidence is this top section here. Overall, in males versus females, these are the populations, about 700 million each, males and females. Numbers of new cancer cases, about 500,000 in men and about 680,000 in females. And if we look at the top three leading cancers, in men, it's prostate, liver, and colorectal. In women, it's breast, cervix, and colorectal. If we look at both sexes, it becomes breast, cervix, and prostate. But if we look at mortality, cancer deaths, what we see is that it's prostate, liver, and lung for men, and then breast, cervix, and liver for women. And if we look at both sexes together, then it's breast, cervix, and liver in terms of mortality. So epidemiology is important because it helps us to identify those at risk and is key to improving cancer control. And as we say, prevention is much, much better than cure. And that is particularly true for liver cancer because liver cancer has causes that are eminently preventable. And so just very briefly, I'll start and go around here. Host genetics is important, and so some of our work is related to try to understand what are the inherited risk factors. And we know very well that if people are in a family where a family member has liver cancer, the likelihood of developing liver cancer if they develop viral hepatitis is very high. But is this because of the host genetics or because of viral genetics? It's not completely sure, but those are important to know about and to better understand in Africa. In terms of viral genetics, we know that hepatitis B virus is a major cause of liver cancer. And as I'll show you, it causes liver cancer at significantly earlier ages in Africa than in other countries. And one of the questions is it due to the viral genotypes? We know that the genotypes in Africa are different than genotypes in other parts of the world, such as in Asia. And we also know that genotype is associated with age at onset. So there seems to be genotypes that are higher risk in terms of early onset than others. But we also know that there's influences from the diet and the environment. And in Africa, particular aflatoxin is a major risk or a major contaminant in diets that is typically from grains and foods that are not dried completely before they are stored. So peanuts or groundnuts and maize, corn, millet are all foods that if they get moldy during storage, they can have aflatoxin producing fungi that will lead to toxicity to the liver, and aflatoxin damages the liver DNA, and it is synergistic with viral hepatitis in causing liver cancer. Then, of course, there's lifestyle factors. Obesity and diabetes and hypertension are associated with what we call non-alcoholic steatohepatitis. That's a major risk factor for liver injury, fatty liver disease, and cancer. Alcohol is as well, and smoking is also. The only positive thing on this slide is that I can say that from every epidemiology study that's been done, coffee is protective for liver cancer. So people always say, the doctors always say what not to do and not what to do. I think at least as far as the liver is concerned, we can encourage people to drink coffee. Okay, so if we look at a few countries and look at hepatitis B and C prevalence rates, I think it's instructive because it helps us understand why we have these high rates of liver cancer in Africa. So this is looking at hepatitis C. The estimate in Nigeria is that there are about 1.3 million people who have hepatitis C. So that's a little bit less than 1% of the entire population. But if Nigeria is a large population, so if you go through and calculate the deaths per day, 15 people die per day in Nigeria from hepatitis C infection. Hepatitis B is much more common. About 7% of the Nigerian population, about 14 million people, are thought to have hepatitis B. Most of these people are undiagnosed, less than 1%, and less than 1% are on regular treatment. The estimated annual deaths about 46,000 individuals. That's about 5 people dying every hour in Nigeria from hepatitis B-induced liver cancer. If we go to Ghana, it's the next most populous country in West Africa. We see here that the distribution of viral hepatitis, and this is B on the left and C on the right, changes as you go north in the country. And so as you go north into the drier, more Sahelian regions, we see substantially higher rates of viral hepatitis B and hepatitis C, with hepatitis B as high as 20% in parts of northern Ghana, hepatitis C as high as 10 to 15% in parts of northern Ghana. So a number of years ago, I and several colleagues started a series of conferences, this group called Africa Partners Medical. This is from a conference for young doctors and nurses that we had in 2023. But we started these conferences around the year 2000, actually in Nigeria, and then now have conferences in both Nigeria and Ghana. But that resulted in the opportunity to meet colleagues from different African countries and beginning to talk about diseases as they were seeing them in Africa, different from what is maybe seen in the rest of the world. And one of the results of those conferences was that we formed a study group, and we decided to try to see if we could confirm this observation that liver cancer occurs at an earlier age in Africans, particularly in association with chronic hepatitis B. So lots of people from different countries. These are the countries that were represented in the study. 3 in West Africa, and we had Sudan, and then 4 additional countries in East Africa. Had a total of about 1,500 patients, and this is showing you the peak age of liver cancer in the darker columns from hepatitis B, in the lighter gray from hepatitis C, and you can see the peak age was in the 35 to 40-year age range for hepatitis B-induced liver cancer. And if we looked at it here by hepatitis B in my age and it versus hepatitis C, you can see here that the median age is about 42 years, but it ranges from people in their teens, of course, into well into their 80s and 90s. And it varied a little bit by country. So Malawi had a median age of 35 years. Ghana, Nigeria, and Uganda had median ages of 40. And then we had some increases. And particularly in Sudan, it was interesting that this is hepatitis B, but in Sudan, you can see that the age was older at which people were developing hepatitis B. But the vast majority of countries in sub-Saharan Africa, we have median ages in the 30s and 40s. Now, if you actually look in the United States, where people were born in the world, you can see these are people who are diagnosed in the United States, but you can see more than 50% of people who are from West Africa, born in West Africa, but living in the United States that develop liver cancer are less than 50 years of age. So it's really important to reduce risk and detect cancer early. If we detect early stage liver cancer, we can actually treat it for cure often. Advanced stage liver cancer, much more difficult to cure. And so it's key, particularly in settings where we have limited resources, to find liver cancer early. And so we have the idea of this cascade of care. We want to prevent the causes. So things like vaccination of newborns, vaccination of children after birth, and actually vaccination of different groups, healthcare workers, adults in countries, to reduce the overall rate of hepatitis B are critical. But we can also prevent the causes by treating hepatitis C, reducing the prevalence. It's important that we identify those at risk, detect cancers early, try to treat cancers effectively, and if possible, personalize the treatment. And I'll be quick here. The main point of this is to say that if you have a population where you identify almost everyone that is at risk, in the world today, that's in Japan and Taiwan. They know almost everyone that's at risk for liver cancer. and they have pretty good early detection and treatment. And both countries have 5-year survival rates for liver cancer that are more than 50%, that are actually close to 60%. The middle really is the situation we have in the United States. We actually only know about a third of the people who are at risk for liver cancer in the United States. And if we have about the same technologies for detection and treatment as they have in Japan and Taiwan, but our rates, our 5-year survival is more like 15 to 20% in the United States. And then lower down is what it's like in sub-Saharan Africa, where we probably only know about 1% or less of people who are at risk. We have much less early detection and treatment capability. And so, of course, no one essentially lives 5 years in sub-Saharan Africa with liver cancer. And our goal really is to change that. So I'm going to skip this and say that the next study that we did is to look at what happens to people when they are diagnosed with liver cancer in sub-Saharan Africa. So again, we expanded the scope of this study now, and you can see we I think ended up with 9 countries here. And what we did was actually study Egypt, which is mostly hepatitis C induced compared to mostly hepatitis B induced in the other countries. And Egypt has more resources devoted towards early detection and diagnosis of liver cancer. And so when we look at survival of patients, in about the 1,200 or so individuals from Egypt that we studied, we had data on about 600 in Egypt, about 600 in the other countries. You can see median survival was almost a year in Egypt, compared to median survival less than 3 months, about 2.5 months in all the other African countries. And I'll skip this here. It just tells you that we find cancers at an earlier stage in Egypt, and there are more patients that are eligible for treatment. And I'll skip this also. Again, we just put Egypt and sub-Saharan Africa within the scope of the other countries in the world. Here's Taiwan up here. Here's Japan with 5-year survivals about 50%. And you can see in the data from sub-Saharan Africa and Egypt, as I discussed it earlier. So it's really important that we reduce the rates of these viruses. Here's data that suggests that if you take patients with hepatitis C and you cure them of the hepatitis C, which we can do now for over 90% of people, it reduces liver cancer rates by about 80%. So we started, as part of this consortium, this effort with the government of Egypt, where Egypt decided that they wanted to treat 1 million people in sub-Saharan Africa for hepatitis C and try to cure them. And so working with the government in Ghana and the Ghana Health Service, we actually initiated this partnership where we screen individuals in Ghana for hepatitis C, and the Egyptian government ships drug for free, and they committed to shipping enough to treat 50,000 people. And so some of these pictures, and actually this was in the New York Times, an article about how Egypt was trying to help the rest of Africa to cure hepatitis C. So we actually launched this free hepatitis C treatment program in Ghana, and we call it Stop Hep C in Ghana. So if you go to Instagram and you search for Stop Hep C in Ghana, you will see some of the public campaign information that we are using, comedians, nurses, other staff. Here's one of the first patients who received treatment. I'm sharing his success story to encourage people to receive this treatment. We've also been active in helping to change the guidelines for the treatment of people with chronic hepatitis B. It used to be that the guidelines were, in a sense, set to exclude people from treatment. And now the new guidelines that were published last year really have a bent of including people or offering people treatment if there's any chance that they might benefit. So I'll just point out one thing here. So who do you treat among patients with chronic hepatitis B to try to expand eligibility? People who have significant fibrosis. If you have a way of measuring fibrosis, there's a way to use the platelet count and the AST to estimate that, or people who have evidence of fibrosis. If they have an HBV DNA is high and a high ALT level, but many parts of Africa you cannot do an HBV DNA at a cost that's affordable. Or though, if you have a co-infection with HIV, HDV, or HCV, regardless of the HBV DNA, if you have a family history of liver cancer or cirrhosis, if you have comorbidities such as diabetes or fatty liver disease, or you're on immunosuppression or have extrahepatic manifestations. So the goal here is to expand the number of people eligible for treatment. If you don't have an HBV DNA assay and you have persistently abnormal ALT levels, that is reason for treatment as well. So we estimate that making these changes through the WHO guidelines will probably make up to 40% of people with hepatitis B in Africa eligible for treatment. And it's important to recognize that we talk about fatty liver disease, and we tend to think that this is a disease of developed countries with higher GDPs. But this is a study among Ghanaian type 2 diabetes patients, where we found that 50% of them had fat in the liver, and almost 12% of them had significant scar tissue in the liver from the fat in the liver. So already we can see that it's important to recognize these, because if any of these individuals then has hepatitis B, they would be eligible for treatment. Now I see we've hit the hour, and I'm going to skip, if it's okay. The next section was about how we improve treatment, how we improve early diagnosis using blood tests. There's a combination of 3 different tests that you can use called the Gallup score that has been shown to be quite effective in Europe and North America. And we actually have recent studies here in North America that have shown quite good efficacy and performance. And so we did this study in Africa, and this was published just earlier this year, showing that it can also work quite well in sub-Saharan Africa. And so again, this allows you to make the diagnosis of liver cancer without an ultrasound. I'm going to skip then to the last section here and talk about the consortium, the Africa Hepatopancreatic Cancer Consortium, and the Aortic Hepatopancreatic Special Interest Group. And we really, as a group, consider ourselves identical. The consortium members, we all encourage them all to become aortic members and be part of the SIG, and so that we can all collaborate together. And it's important to have a consortium because this is data from the Cancer Genome Atlas project that was performed a number of years ago by the National Cancer Institute. And when they did the pan-cancer analysis of whole genomes, someone made this plot of where the samples came from that were included in this analysis of whole genomes. And that's what's shown in blue. And as you can see, there were essentially no samples from sites in Africa or in South America. So it's important that we form collaborations like this consortium to address this. And I'm just going to skip. We were fortunate to get funding from the National Cancer Institute. And so we started, we had the first conference in Cairo in Egypt in 2022. Here's the initial group of about 160 people that met there. And then we had the second conference in Accra in Ghana in 2023, had about 220 people that were participants. And just had, these are different workshops that we had at the second meeting in Accra. And then here is the third conference that was in August in 2024. And here are a few pictures again from ultrasound workshops, endoscopy workshops, the poster session from the meeting that was in Mombasa in 2024. We're actively planning the next conference. I just put this up here to show that the majority of attendees at these conferences are early career physicians, scientists, and investigators, people who are postdoctoral trainees or pre-doctoral. So we really have a focus on training young scientists. We've started a biorepository effort. So in green on this map, you have the active biorepositories in different countries. And in yellow, we have the biorepositories in development. And then in the dark brown or black countries that where we've had participants participate in the consortium meetings, but where we are yet to establish a registry and biorepository. And so I'll stop there. Sorry to have gone over, and hopefully we can take a few minutes for questions.
Thank you very much. I think there's a question in the chat by Yehoda. And the question was, is the higher rate of viral hepatitis in North Ghana related to vaccine hesitancy versus biology? And similar for early age of HCC onset, is that related to younger age of viral transmission? Anecdotal stories of infant infected mostly through transfusion. And then finally, she wanted to know what your consortium was doing regarding screening blood bank products. That's a lot of questions, Yehuda.
So I think the first one was about the Northern Ghana gradient. It's really interesting, and I think sort of we're actually working on some epidemiology studies to try to better understand this. Studies that have been done before suggest that there's potentially some cultural elements to this, because there's practices such as scarification, there's practices such as circumcision that are traditionally done by traditional attendant or a traditional health practitioner that often is using the same implement to circumcise multiple individuals. And so the idea is that it's likely that there are actually cultural practices that have resulted over time in the high burden. But you're exactly right. Hepatitis B is transmitted from mother to child, potentially during childbirth. So if a mother has a high viral load, she will likely transmit to the child. That actually happens more often in Asia than in Africa, but there's definitely a percentage, perhaps 10 to 20% of transmissions in Africa, maternal to child. There's also a lot of transmission in Africa that is between family members and children at their early stages of life before the children are up to about 5 years of age. So they can pick it up from other siblings or from implements that are used communally in the home. In terms of the young onset of hepatitis B, broadly, we think that yes, that it's likely that that is partly, at least partly, due to the fact that the transmission occurs at such an early age. But it's important to recognize that a transition occurs at an early age in Asia as well, but the age of onset of cancer is typically later. Even the earliest ages of onset we see in cancer in Asia are median ages in the 50s, whereas we are seeing here median ages in the 40s. And so we think there's more to it than simply the early age of acquisition. And that's where maybe things like aflatoxin exposure and potentially genetic risk may come into play. And then in terms of blood screening, there's active efforts in multiple countries for screening the blood supply. And so I think I would say that we've seen a substantial improvement in that in the last maybe 20 to 30 years. But clearly, we likely are probably not where we would like to be. Great questions.
Thank you very much. So I think we're almost at the hour. I really want to be respectful of people's times. The other questions can be emailed. 1 hour is never enough for this kind of sessions. It's always very informative and mind-blowing. And we hope that this is not the end of Mayo Clinic gracing us with their presentations, their talk, and the wonderful things that they are doing. And I really want to thank the presenters, their collaborators who have been on this call, the attendees who has made this event. And we hope to see you next month. Next month, we have Purdue University is going to be presenting. We have Dr. Salma is going to be presenting. I hope that people just attend, and not just when we see one person, everybody wants to attend. And, we just have to keep up going. And this is exactly the reason why we decided to start this Aortic North American series. It's an opportunity for us to know what everybody is doing. For us to know, as a Yoruba woman, I would say for you to know what the left and is doing and the right is doing. person. And we hope that we are going to continue to attend this. And the goal is that we know each other. We come together in one of these conferences to discuss our challenges, because what we see, I can tell you for free, is everybody is beginning to have the same challenges as far as when they want to conduct their clinical trials, as far as the logistics of it all. So a quick announcement, I already put that in the chat. We have aortic meeting coming up during ASCO May 31st. We have Best of ASCO Africa, the first in person. I need to thank Professor Lewis here being part of the planning committee for this event to happen. I'm excited. It's going to be occurring in Ethiopia, Addis Ababa, June 27th and 28th. And the theme is we are access to innovative therapies and technologies. We hope you join us in person. Professor Dejino, Professor Lewis, we this is interesting. I cannot thank you enough. I have a lot of questions myself, but I just want to be respectful of people's time. Thank you so much. And do you have any questions or anything to add, Prof. Lewis or Professor Dejino?
No, thank you for inviting us, and hopefully everybody will come to AOTIC later on this November, and we will continue the dialogue. But please feel free to email Fahia Omar at that email address if you have any questions for us.
All right. Thank you very much. Bye-bye.
Thank you.
See you all next month. Bye-bye.